I do a little work as an amateur magician. In fact, I almost set the stage for Rent in Broadway on fire when I was up there doing a lecture and had some open flames. I'm only going to do one trick for you guys today, and it's not my best one, but I always have to, at educational seminars, make an educational point because you're not allowed to be entertained at a CME event. Okay? So you're all going to start out like this coloring book as a blank page. So whatever perception you have of direct primary care, if you have any prejudices, if you think it's one thing or another, put that away because I think all three of us are going to show you different versions. Hopefully by the end of our session though, you'll have sort of a framework for what it looks like. And maybe by the time all three of us colorful characters are done, you'll have the full view. Okay, but don't leave today and forget it all. All right, so this is a lot to pack into a 20-minute session. I'm going to do my best, and I'm not going to try to beat you guys to death with PowerPoints, but there is some important information I'd like to share that is on here. So first of all, you guys have heard the triple aim bantered around over and over and over again by lots of government officials. I think they left out the most important part, which is the fourth corner here, which is the experience for the physician. Everybody wants lower cost, people want better quality, they want improved access, but we've left the physician out of the equation, and it's important if we're going to reform healthcare, if we're going to improve how we're taking care of patients, that it's also better for physicians and sustains us. We've got at least 3 medical students here in the audience, and medical students are watching. They see what doctors who are in burned out clinics look like. And if we want physicians to take our place and provide high quality care and not have shortages, we need to sort of emulate and mentor them in a good way to do that they can thrive in. So just real quick, what are people thinking across the country? It depends on what venue I'm at as to what people think. You know, I was just at an AAFP meeting and they thought everybody was going to do a PCMH and become an ACO. They had data talking about direct primary care and the numbers were much less than I thought. This article is much better. It says that 53% of people are considering or already in a direct primary care model as of 2014, and that 35% are already in a concierge model, but only 20% are working towards or have achieved PCMH recognition. When people talk about new models, you guys heard about MACRA earlier and the advanced payment models. When you look down here at ACOs and PCMH, you know, the people that have entered that already are sort of dwindling, and a lot of docs just think they can't sustain their practices with those models at this point. So what is direct primary care? What are the pros of it? Simply, it's kind of like a gym membership for healthcare. We'll talk a little bit more about the details of that in a second, but what are the benefits? It is significantly lower out-of-pocket costs for most people. When I started doing this model, I had 2 reasons. One was a selfish reason, which was that I was at a practice where we were seeing 16 patients per half day. I felt like I was spending more time filing forms and claims and that type thing than I was spending talking to patients, and I really didn't like that. So the selfish reason is I wanted to be able to slow down some and take that time that you heard talked about earlier with my patients. The second reason was that I saw the uninsured patients were actually getting charged these outrageous rates. You know, the insurance contracts, one of the dirty little secrets of a lot of those contracts is that they say if you see somebody who doesn't have insurance, you have to charge them a higher fare. Sort of like that, you know, the rate on the back of the hotel door that nobody really pays. That's what the uninsured people have to pay. So didn't want patients to have to do that. So I was looking for an option that would actually help improve access for people that were uninsured or who had high deductibles or that couldn't afford normal care, but at the same time trying to make things better for myself. And I think this model gives you complete price transparency. People know exactly what my prices are. In fact, I got very self-conscious when the Weekly Standard published on their cover a picture from my waiting room of my entire price list. They did that several years ago, and every Barnes & Noble I went in, I would see my price list from my waiting room on that cover. Makes you a little self-conscious. That's complete price transparency, though. It lowers overheads significantly. There's no doubt that practices can be financially better off. I subscribe to the Benjamin Franklin philosophy that sort of, you know, a penny of overhead saved is a penny of net revenue for the practice earned. So you can definitely decrease your overhead when you don't have the staffing involved with filing insurance, filing claims. And the uninsured and poor, I don't forget that as part of my mission. Although now we have mostly insured patients in the practice, when I initially opened, the plan was to actually have 90% uninsured. And we did get a lot of uninsured patients, but now all of the insured people that have found out about the model and that want to be cared for, where they have a 45-minute or an hour-long visit instead of, 7.5, has sort of taken over. What is the major con? Well, it's a disruptive innovation. It's a big deal for your practice to do this if you're in a traditional model. It's not like adding on a few bells and whistles on a bicycle. It's like throwing a stick of dynamite in the spokes while you're riding it. So it is very, very disruptive. And some people, have a trouble convincing patients of what the value is, recruiting that patient panel, because there's such a copay culture out there where people have really equated the value of medicine with their copay. It's kind of depressing, but you guys should think about the fact that copays now are less than, and the amount that you get paid per patient net is less than what the average person cutting hair in your neighborhood gets for a haircut. It's an interesting statistic. This picture comes from old family practice management, I think from 2007. And I have this guy on here. He's sort of famous. He's one of my patients. He's still one of my patients. He didn't have insurance for years. He does have a subsidized ACA plan now. A reporter asked me, well, are a lot of your patients going to leave now with the ACA and everybody has insurance? Well, first of all, when I started my practice, there were 83,000 uninsured people in Wake County. And this year there's 85,000 uninsured people in Wake County. So the ACA hadn't made a big difference. This guy, we're pretty much the only access he has. So he takes a bus from about 30 minutes away to come to our practice. And my very favorite moment was one day I looked out through the glass partition, and out in the waiting room, this guy was sitting, and right next to him was a multimillionaire. And the multimillionaire had driven 2 hours away from Wilmington. And in an instant, what I realized was both of them had access to the same quality of care. And if you asked the homeless guy why he came to my office, he'd say it's the only thing he can afford. If you asked the millionaire why he came, his comment is, because I can't pay any doctor in Wilmington enough or more to get the type of care I can get here. And as was said earlier about being out of network and a free agent, we need to offer excellence. We don't need to force patients to settle for average. So what makes this work? Everybody's always worried with models where you don't take any insurance. And sometimes I tell people I'm a recovering insurance addict, that I've been sober now for 14 years. But I haven't taken a single dime from an insurance company in 14 plus years, and it feels really good. So, but how do you afford to do that and stay in practice? Well, this is a key, is reducing the overhead. The average overhead nationwide is about 65%, and we've reduced ours to 18%. We don't have a biller, we don't have a coder, we don't have anybody who checks for clean claims, so we reduce the overhead dramatically. And just like Benjamin Franklin, that's how we're making it work. We're saving about $250,000 per physician in the practice. And so you have that extra $250,000 to sort of put back into the budget. This is the math of my model laid out very simply. The left side is a traditional system with 65% collections, 60% overhead. That leaves you as a physician with 26 cents out of every dollar. On this side, you have us with 99% collections after going on our 14th year with 18% overhead. We're probably actually going to be 16% overhead this year, which leaves 81 cents. If you charge a patient 50 cents in this model on the right, you still make more money. You still come out 50% better by charging the patients half as much. So that's really the thing that makes it work. I throw this up here for two reasons. Number one, it's a great airbrushing of me. I think they took off 10 pounds at least. But mainly to show you this, keeping it simple. I sometimes explain this model, and what it turns out you guys, a lot of you do, is we've just cut out the middleman. We've gotten him out of the way. My very first job was mowing lawns. And when I used to mow grass, it was very simple. I would pay my neighbor he would pay me $20 to mow his grass, and the transaction was done. And what's happened in medicine is that we've allowed it to be so that I have to pay one of my neighbors $10 to submit the bill for cutting grass, And then I have to pay another friend of mine $10 to make sure I get my grass cutting money. Well, what happened to your $20, right? So simply, all direct primary care does is it eliminates that, so you're directly paying the physician again. I think the gyms got it right. They have a lot of genius. You've never been into a Gold's gym and get on a treadmill and they say, well, let me write that down, that'll be $5. And you lift a 3-pound dumbbell and they say, let me write that down, that'll be $3. If they had to have somebody follow you around and code everything you did at the gym, the memberships would be astronomically higher and no gym would be making a profit, yet that's the insanity of what we're doing in primary care. So simply put, this is a membership model. People pay a retainer, they pay a monthly fee, and then they take advantage of the services offered at the medical practice. Charge a low member per month fee. I've been told by several attorneys it's not a good idea to talk about specific pricing in organized medicine arenas, but we do charge a very low monthly fee, less than the equivalent of a carton of cigarettes, which means North Carolina affordable. And it's less than the very cheapest cell phone bill you could get at Walmart, right? And doing that per month, we can still make it so that the incomes for primary care approach that of all the internal medicine subspecialties because of that $250,000 of overhead we got rid of. In summary, there's 80% less usually charged to patients. The collections are much higher. The more time with patients, I think, has a major, major impact. And I'm going to show you guys some slides on that in just a second. We're not bound at all to any contracts. The only contracts I sign in my office are the ones I wrote. And those contracts are typically with patients. They're contracts to do their care. So it doesn't matter out of network, I'm out of network for everybody and have been for 14 years. It's much less stress. You know, I have yet to meet a burned out DPC physician. It just doesn't seem to exist. Gives better familiarity and firmer patient relationships. When you look at malpractice rates, malpractice premiums, I pay a reduced rate specifically for practicing this model. These other physicians may as well, but there are companies out there that offer, straight off the top discounts for any physician who's operating in this model because they know you're less likely to get sued. Your relationships with patients are better. The time you spend with patients is more. So you're able to do that without having any concerns at all about the communication breakdown that can happen. And people talk about being a medical home. Well, if you've got 45 minutes to an hour with each patient and you're specifically focusing all your care on them, and the first question that when a patient calls the office is not, what's your insurance? Because we never ask that. We always ask, what do you need? What do you need us to do for you? So I show you this picture to show you I can be flexible, although I won't do this for you now because I'll split my pants. But this is, I think, the most important part here, is that a doctor-patient relationship is exactly that. It's a doctor-patient relationship. And we've got to kick the insurance companies and the government out of the exam room. They don't belong there. They have no training in medicine. They can't empathize with patients, and we've got to get them out so we can get back to the joy of medicine, which is truly forming that relationship and taking good care of patients. I want to show you guys just a little bit of outcomes. I know we don't have time for a lot of this today, but I just want to show you a few things. This is data from QCAP, which is a not-for-profit out of Wake Forest University. On the far left, you have 27 traditional PCMH practices. In the middle, you have hybrid DPC practices. Those are practices that take some insurance, but also have DPC patients. And then on the far right, you've got DPC practices. I think they took about 3 or 4 practices for this data on the right. And you can see the systolic blood pressure, the LDL, and the HDL goals, and this is based on old ATP3 and JNC7 goals, was much, much better. And this was risk stratified. They adjusted for all the variables for the sickness of the patients and everything else. And it shows you that you really can provide outstanding care when you can have more time with patients. What about physician income? Well, I'm going to tell you, medical students get excited over direct primary care, and it's not just because they don't get burned out. When you have a medical student that's got a $200,000 debt, and they're wondering how they're ever going to get that paid off and if they're ever going to be able to get their first house, if you tell them they can pay off their debt in 6 months in this model, that they can make the same amount of money as a gastroenterologist or a cardiologist or an orthopedic surgeon doing primary care and doing it with like 10 to 12 visits a day, well, you've got their attention. So a lot of people will tell me, well, it's not about the money. Okay, well, for you, if it's not about the money, that's fine. But for medical students and people who are considering careers, especially in primary care, the money does matter and it is important. Sometimes people say, well, what about for really disadvantaged areas, really poor areas? Well, we've got a practice we just opened in one of the poorest communities in North Carolina, very rural community called Williamston. And in that community, they're charging probably the lowest fees in our entire network for DPC. And you can charge half as much as the national average for direct primary care fees and still make 50% more than the national average for primary care. And those are low amounts, so that's half a carton of cigarettes, okay? Blood pressure control, 50% is the national NHANES data. In North Carolina, it's only 33% of patients are at goal for blood pressure. In this study, this was done by North Carolina State University's MBA program. They assessed the model over a 2-year period for some students getting their master's degree, and they found that 80% of patients in DPC practices in the area were at goal as compared to 50% nationally. This is also an interesting slide the NC State students did. It's based on this sort of famous government slide about how much every country costs. And you can see that North Carolina or United States definitely is off the charts here. But what they did is they graphed the cost for my patients out of pocket over a 10-year period. And what they found was that it was less than every single other country. And look how flat the slope is. There is a slope there. There's an increase. We've raised prices over the last 14 years, but it's fairly flat. Then the students took and compared the experience, and one of the things they looked at, people are always interested in, is what about hospitalizations? Well, there was a 60% reduction in hospitalizations. There was about a 65% reduction in ER visits. And when you looked at the amount of time that patients normally spent in the North Carolina area, it was 20 minutes per year of face time with a physician. Yet at DPC practices, it was 140 minutes of face time a year. You guys will hear lots of stuff about motivational interviewing and trying to help people with better lifestyle and stopping smoking and things like that. But the problem is in 20 minutes a year, you can't do any motivational interviewing. But I'll argue that in 140 minutes in front of a patient in a year, you can actually get something accomplished. Key problems this solves. Viability of independent practices. If I had to say I have one mission at this point, it's throwing that sort of life raft to practices that are struggling and sort of pulling them out of the water and helping them survive. I have had 2 physicians in the last 6 months who came to me who were seeing 30 patients a day and making less than $70,000 a year. And realizing next year is going to be worse because their overhead keeps rising and their reimbursements aren't. And so that's my real mission, is to try to bail physicians out of that and show them a different way to do that. Workforce recruitment, med students love this. The ones, we've got at least 2 in the room who are rotating in my office, and I don't think they'd ever heard of this maybe until they came to my office, but I would say they're probably considering this model now. You guys, wouldn't you say? Okay. Probably considering it. Access to primary care, maybe not for everybody. There's a place for Medicaid for the poorest of the poor, but access for most. And the government and insurance bureaucracy is incredibly decreased. People ask me about meaningful use, and I say, well, okay, it's not really meaningful because it doesn't mean anything to me. I'm not going to take any checks from the government for that. I have patients that come to our office that are particularly Medicare age that are sort of what I call off-the-gridders. They're people who say, I don't want to be in the meaningful use system. I don't want my information in that. So that's why I'm coming to you as a private patient and wanting to get private services. And then quality metrics and value are built in, because the other guys are going to tell you this, I know Josh in particular will, that employers and policymakers want to know, is this model better? So it's sort of really important for us to prove it. And so we're using at least 4 data streams from 2 different universities and a not-for-profit and different sources to really validate that, yes, this model is good for cost. It's good for the triple aim, which everybody's worried about, but it's also good for physicians. This is a quote from a medical student that was put on a blog called Kevin MD by a medical student who rotated with me a couple years ago. And I'm not going to read it to you guys, but you should read it in the background. It's very powerful. This was just the last paragraph of what he said. He entered my practice wanting to be an anesthesiologist. He was told, he had always his whole life wanted to be a family physician. Went into the military, did his military service, went to medical school. They told him, you won't be able to afford to pay back all your stuff that you owe if you become a family physician. And I'm happy to say he's in his intern year now in a family medicine residency, and he's going to have a DPC practice in Wilmington in 2 years. Won't talk a lot about the significance except to say it's really taken off like gangbusters. You guys probably have heard some things about some of the conferences that have been happening, but the Medscape article says 33% of all independent physicians are going to be direct primary care equivalents by 2016. Insurers, although it's an ugly word, I do think at some point they're going to come around to basically, they're going to be begging for you guys to come back. And when they beg for you to come back, it's going to be the game on your terms. Hopefully where they say, look, patients come into your practice, whatever your membership fee is, we're just going to pay that. We'll just pay that every month. No claims, no 99213s. I hope we get to that place one day. Large companies are doing this. Expedia.com, the Freelancers Union, Whole Foods, Grove Park Inn in Asheville. Lots and lots of big employers are starting to embrace this where they actually pay the monthly fee on behalf of patients. Right now, this is our footprint. Obviously, North Carolina is fairly saturated, but these are practices that have sort of joined our network over the years. Some of these have come in person to Apex, a lot of them have, and we've spent time sort of teaching them about the model. And some of these stars may represent 1 or 2 physicians. Some of the stars, like in Tennessee, represent 70 physicians. One of the ones up in New Jersey represents about 80 physicians. But this is what's happening. Physicians all over the country are clamoring to sort of do this model. Here's some references for you. I'll just throw those out. The Twitter feed is probably a good place to get updates because usually if there's a DPC article that comes out, I'll throw that on there. And then here's some websites you guys may be interested in. You also, I think, Jeremy put an insert in your packet that has contact information for us, for the not-for-profit, and also for our network if you're interested. So I'm going to stop there, but I'm going to say that practicing in this model for 14 years, starting it when people said I was nuts, that it was crazy to basically not take insurance. I've really, really enjoyed it, and I think it's the only way that really I can ethically practice as an independent physician. And I hope that changes, but if not, I'll still be doing DPC, the next 30 years, hopefully. So thank you very much.